Well, hello everyone. This is Chris back again with the Ancient Scholar. So today I actually took both examinations, board exams for the Registered Respiratory Therapist, the RRT. I took the written exam in the morning, and then actually almost right after I finished the written exam, I went right into the clinical simulations. Now, I probably would not recommend most people do this. You have to know yourself very well, and I think if you're pretty confident and you're good at taking tests, you don't fatigue very easily, then doing it this way would be within your limits. You can do it this way. You can schedule both exams at the same time. However, after having taken the clinical simulation exam, I would recommend most people not do it the way I did. I know myself fairly well. I'm fairly decent at taking tests. I'm fairly disciplined, and it's generally not a problem for me to do something like this. But the operating tempo is very high, and as you guys will find out hopefully here pretty quick, the clinical simulation examination is like nothing that you've probably ever experienced before. So naturally there's going to be a high level of anxiety already associated with the clinical simulation. And secondly, if by some chance you happen not to pass the written examination in the morning, I personally don't know what exactly that would do for me, but I think most people would probably be destroyed as far as their self-confidence goes, and that I think that's just being honest. That's just an honest assessment of what would happen, and honestly thinking about maybe if I'd failed the written, my self-confidence would probably have been destroyed, and I would have been probably not particularly effective at getting through the clinical simulation. So I took a risk today, and it paid off. I passed, so I'm now a registered respiratory therapist. But is it a risk that I would necessarily tell people to take? Probably not, unless you're very confident and you're very self-assured and you know yourself very well. So let's just kind of talk about the written, not the written registry, but this clinical simulation exam, and I may end up having to do a couple videos on this. Like I said, this examination is like nothing you probably ever experienced before. It certainly is like nothing I've ever experienced before. The closest that I have come to something like this is when I took my national registry for EMT Basic, EMT Intermediate, and in that. There's something called the psychomotor skills examination, where you're actually doing hands-on skills and being graded. The difference is you had a very well-defined, idea of what you needed to do when you took the National Registry psychomotor examination. You had sheets that you can get from National Registry of Emergency Medical Technicians, and they'll tell you exactly what you need to do to pass that exam. The clinical simulation exam is not like that. The next thing is the clinical simulation exam is not a hands-on exam. So you're not actually doing hands-on, you're not actually personally interfacing, but you're put into a situation where you kind of have to imagine that you are. So some of you are probably familiar with this, but I'm going to come at this from the viewpoint that maybe some of you are just graduated and you're not particularly familiar with the clinical simulation format. So the clinical simulation format is just like the written CRT and the written registry exam, that it's on the computer, it's computer-based, but the difference with the CRT is that it is all scenario-based. You are given scenarios. For the RRT clinical sim exam, you will have 11 scenarios. So you'll have 11 different patients or patient scenarios. There are some scenarios that may have multiple patients. So already something is very interesting here. So you have 11 patient scenarios, and you're given up to 4 hours. 4 hours to do this examination. The CRT was 3 hours. The RRT written was 2 hours. I don't think I mentioned that in the RRT written video. I apologize. Hopefully you guys are watching this. I may just put some annotations into that RRT video, but you're only given 2 hours, but you're given 4 hours, so clearly some of these scenarios can get rather involved. So the basics, you have 11 scenarios. 10 scenarios are graded, so they actually count. One scenario is what's called a pilot scenario. It does not count. They don't even tell you how well you did on that scenario. Okay, so 10 scenarios, but I have to do 11 and I have 4 hours. So that's about 20 minutes a scenario. It took me about an hour and a half to 2 hours, I believe, to finish the clinical simulation exam. I'm usually very quick at testing. It only took me about an hour and a half to do the 160 question CRT written, and a little under an hour and a half to do the 115 question RRT written, but it took me a full 2 hours for this. So clearly this is a fairly involved exam. So how is it structured? We'll talk about the structure. Well, it's structured in that when you start your first scenario, you'll read on the computer screen, and you'll be given a scenario, and it'll say something on the lines of, I don't know, just make something up. A 60-year-old male is in the emergency room. He is complaining of dyspnea, and the physician has called you to evaluate the patient. And that's how every scenario starts out with. And there are actually two major components to these scenarios. There's an information gathering component, and then there's a decision-making component, and the components are graded separately. So you have to get so many points in one, so many points in the other to pass. So generally what happens is you'll be given a scenario up front, and then they'll say, okay, the physician asks you to come into the room, and then you'll have a big old laundry list. I mean, I'm talking, you know, somewhere in around 20 things, perhaps 25 things, perhaps, that you're going to have to look at all these things, and you're going to have to look at a scenario, and you are going to have to make a decision on what things you want to assess. Now, this was very difficult for me as a nurse, because as a nurse, as an emergency medical technician, as a flight nurse, the way I assess patients is very differently. I do a full head-to-toe assessment, and it's a fairly detailed head-to-toe assessment. The respiratory therapy examination process is very specific. So there are certain assessments that you don't necessarily want to do, and the RRT they're not as holistic, if you will, as nursing, in that if I over assess, it's okay, it's safe, because you want to over assess. You'll fail if you do that on this examination. Those are what we call acts of commission, where you're doing too much. So, and likewise, if you do too little, if you don't do the right assessments, you fail. So you have to find that happy medium, and that has been my biggest obstacle to getting through these exams. Is what do I assess and what do I not assess? So what I generally recommend is, when you do your assessment, start off basic and do what I call the visual things. Assess visual things first. Things like sensorium. How's my patient? They alert, they awake, they oriented, they talking to me. What's their sensorium? What is their pulse oximetry? I can see that. What is their respiratory rate and pattern? What does their skin look like? What does their chest look like as they're breathing? You want to look at those basic things. You check those things out first. And if you don't identify a critical dire emergency, like somebody in cardiac arrest or somebody dying actively, then you can move on to more advanced things. So I start at the basic things, and I move on to what I call my touchy-feely tests. And this would be things like listening to the lungs, percussion, palpation, feeling the chest, fremitus, agophony, blood pressure, temperature, listening to the lungs, the vital signs, What do I see in the cardiac monitor? So those are kind of the touchy-feely things. And then if you don't identify dire emergency, then you can move on to what I call the advanced assessments. And this would include a chest x-ray, a complete blood count, a blood chemistry, let's see, a chest x-ray, a complete blood count, a chemistry, and an arterial blood gas. Those are the four major, what I would call advanced tests. And then sometimes you might even get into what's called a specialty exam, but you only do that if there's no identified emergency and your patient is, for lack of better words, stable, or they're maybe not stable, but they're not actively dying. If at any point you realize that your patient is actively dying, you're done assessing, and you hit continue and move on to decision making. What do I do? But if there isn't an emergency, you assess and you go up to you start off basic and you go up to the advanced things, and there are specialty tests. But if you order a specialty test, you need to have a good reason. You need to have good reason to do it. For example, maybe a kiddo of a certain age comes in and they're drooling and they're tripoding and they're febrile, and you go, okay, this is a clear picture of epiglottitis, and I want to do a specialty test, and that would be a soft tissue neck X-ray. But don't do that stuff. Don't do these special tests unless you have really good reason to do them. That would be my big tip for the information gathering. Okay, so you'll gather your information, and it'll kind of tell you a story. In things like patient history, signs and symptoms, definitely pick those. Always pick those. Those are basically because you can see those in the chart. Pick all those. Those are free points. Make sure you don't miss out on any of that. And then after you do that, you'll go into what's called the decision making, where, okay, you kind of have a picture of what's going on, and the physician will say, well, what do you want to do? And then you'll have to make a decision on how to intervene. Now, and generally, these scenarios are going to start off basic. You'll look at a patient, and right away in the scenario, this guy, he's going to get intubated, I know it, and he needs to go to the ICU. Do not put that right away, unless it's clear, unless there's an emergency and you need to do CPR and all that. But if it's not an emergency, yes, the patient may eventually end up getting intubated or whatever, but try to be conservative first. Put your, let's say the patient's SATs are low, and you want to do oxygen, and put them on oxygen. You start off basic, and then what'll happen is, generally, you'll do oxygen, and the physician will either agree with you or disagree with you. And if you get that disagree, that causes a lot of anxiety. You may or may not be wrong. You don't know. If the physician disagrees, just stop, take a breath, and choose the next appropriate answer, what you think is the appropriate answer. The disagree does not necessarily mean you failed. Once you've made a decision, you put them on some oxygen, for example. I'll just say oxygen, or CPAP, or something like that. Some oxygen. We'll stay with oxygen, because that's the first medication you always want to give, oxygen, if you need it. And then generally what will happen is it'll say, okay, this is what the patient's doing now. What do you want to assess now? And then you have to go through that all again. What are the appropriate things to assess? And they're going to have lots of junk in there to throw you off. They'll have VDVT, compliance, pupil reaction, echocardiogram, CT scans. They're going to have a lot of crazy tests in there, and you got to recognize that those tests are not indicated unless you have really good evidence. Let's say the patient has a pulmonary embolism, you have really good evidence for that. Then you can look at a specialty test, but certainly not right away. So you'll go ahead and do another assessment, and then you'll have to make another decision. Okay, what do I do now? Okay, the patient is now in profound respiratory